Welcome to the funnel effect. Today, we are taking a deep dive into, well, one of the most mechanistically and strategically challenging areas in interventional cardiology. We're talking about optimizing complex heart procedures, specifically coronary bifurcation, PCI, especially when you're dealing with, real-world resource constraints.
Exactly. And we're going to be dissecting some crucial guidance from what's really an essential manual for interventionalists pretty much everywhere. Our source material today is an authoritative paper. It was published back in Eurointervention in 2018. The title is Step-by-Step Manual for Planning and Performing Bifurcation PCI, a resource-tailored approach.
Okay.
And this guidance comes from a really experienced global group of authors: Dejan Milosinovic, William Wins, MP Konitseka, Farrell Hellig, Awad Mohammed, and Goran Stankovic.
Wow, that's quite a list. I mean, that really represents the cutting edge of expertise in this field. So our mission for you listening in isn't just to, summarize this manual. We want to distill the thinking behind it. We need to pull out those specific, absolutely non-negotiable steps and figure out the minimum technical requirements for a successful bifurcation PCI, that's percutaneous coronary intervention, really focusing on how you maintain safety and quality when, frankly, the cupboard might be a bit bare.
Yeah, and bifurcation lesions are a huge challenge. You see them in maybe 15 to 20% of daily PCI cases.
Yeah.
But the difficulty and the resource demand, it's way out of proportion to how often they pop up. The fundamental mechanical issue we're always juggling is that when you stent the main branch, the MB, you're running a real risk of messing up or even completely blocking the flow in the side branch, the SB.
Right.
So this manual, it provides a really crucial framework for navigating that trade-off, balancing, the state-of-the-art techniques with these necessary resource-sparing approaches.
Okay, so it's kind of a blueprint then for delivering high-quality care even if you don't have access to absolutely every top-tier tool for every single step. Sounds like we're defining that absolute baseline, the thresholds of what's acceptable, making sure we minimize both that immediate risk, the periprocedural SB occlusion, and also the longer-term risks like stent thrombosis and other ischemic events.
It's precisely. It's about finding that safe, effective minimum. Maybe let's start with why this procedure is so costly, in the first place. Treating these complex coronary junctions, it demands precision. And often, it requires redundancy.
Redundancy? How so?
Well, it means you often need multiple specialized guide wires, several balloons, sometimes different sizes, different compliance types,
Okay.
and potentially multiple drug-eluting stents. Now, if you're doing dozens of these PCIs every month in a setting where maybe the supply chain isn't perfect, those costs, they add up really fast.
I can imagine. And the risks are just inherently tied to that complexity, aren't they? I mean, when you're dealing with such a dynamic junction, every single move you make has an immediate, potentially major consequence. So this kind of high-stakes environment really demands a default strategy, one that's clinically proven but also materially economical. And according to the source, that default approach is the provisional SB stenting strategy.
That's absolutely right. And the evidence really backs it up as the standard approach for, the vast majority of patients. The core idea, the postulate, is a powerful one. The entire procedure has to be driven by getting optimal MB stenting done first. That's job one.
Okay.
The SB intervention. That's strictly conditional. You only really consider stenting the SB after the MB stent is in place, and only if there's clearly significant flow impairment like DMI flow less than 3, or, a severe stenosis that's definitely hemodynamically relevant.
So even if the SB looks a bit pinched on the angiogram, if the flow is still good, the manual's basically saying, trust the clinical outcome over the picture.
Precisely. That's the crucial priority setting right there. Long-term clinical outcomes, they overwhelmingly depend on the sustained success of that MB stenting. Therefore, optimizing the mechanical result in the main branch, it just has to take priority over chasing a perfect-looking picture in the side branch. And that philosophy, it's fundamental to justifying this whole resource-sparing approach.
Right, that makes sense. Now, to help structure this deep dive, the authors use this color-coded framework. It sort of organizes their decision-making. I think that's a really great tool for you listening to help absorb all this information clearly.
Yeah, it really is the operational language of the manual. It breaks down like this. Green. This is the ideal. The recommended approach. The current state-of-the-art using all the best gear and techniques.
Got it. The gold standard.
Orange. This defines the minimum technical requirement. This is your resource-sparing strategy. It's the threshold you need to hit for achieving adequate clinical results. Safe, but maybe not perfect.
Okay, the baseline acceptable.
Red. And this is the hard stop. These are procedures or steps that are just not recommended. Why? Because they're potentially harmful, or they lead to clearly suboptimal long-term outcomes. Doesn't matter what your resource situation is.
Right, don't go there. Okay, so by systematically looking at each step through this green, orange, red lens, we can really get a handle on the acceptable boundaries of, let's say, a procedural compromise when needed.
Exactly.
Okay, let's move to step one then. Baseline assessment of anatomy. Now, I'd argue this step is maybe the most critical, because if you get the anatomy wrong at the start, well, no amount of fancy green zone equipment is going to save the outcome, right?
That is absolutely true. A successful strategy hinges on really understanding that bifurcation anatomy. And this is one area where you just can't cut corners. The minimum requirement for assessment, the orange baseline, if you will, is getting images from several different angiographic projections.
Several different ones.
Yes, and crucially, often including non-standard views.
Why is that multi-angle imaging so critical? I mean, if you're trying to save on contrast dye or maybe cut down on fluoroscopy time, why wouldn't one standard view be enough?
Foreshortening. That's the enemy here. A single standard view can severely misrepresent how bad the stenosis actually is, or the true lesion length, or, very importantly, the real angle of that side branch takeoff.
Oh, I see.
So if you underestimate the severity or the complexity because of foreshortening, what happens? You'll size your stent wrong, you'll pick an inadequate wiring strategy, or maybe you won't even recognize it's a true bifurcation at all. Taking those extra, maybe non-standard projections, that's a non-negotiable safety measure that actually comes before resource constraints even enter the picture. It's more of a cognitive investment, not really a material one.
Okay, that makes sense. So once you've got those good images, what are the three key assessment points the operator absolutely has to establish?
Right, there are three main things. First, you need a precise assessment of the three diameters involved: the proximal MB, the distal MB, and the SB itself.
Okay, the sizes.
Second, the lesion length, and really crucially, the plaque distribution. Is it off to one side? Is it heavy? Is there calcium in there? And third, the exact bifurcation angle and the condition of the SB ostium, the opening of the side branch.
Okay. And this leads directly to defining what constitutes a true bifurcation. What's the specific functional definition, and why does identifying one immediately raise the stakes, especially for resource management?
Good question. A true bifurcation is defined by having significant narrowing, usually more than 50%, in both the MB, either proximal or distal segment, and the SB.
Both have to be significantly narrowed.
Exactly. If only one branch is significantly diseased, technically it's not considered a true bifurcation. And the practical difference is stark. Intervening on a true bifurcation carries a dramatically higher acute risk of compromising that SB during the MB's stenting. So if the operator recognizes this up front, they know immediately they have to step up their game, allocate more resources like definitely wiring the SB, even if they're in a constrained setting.
Right, the risk profile changes completely. Now, the manual does acknowledge that the decision whether to actually intervene on the SB is complex. It often relies on, well, subjective judgment that goes beyond just the angiogram. What are the clinical factors that might push an operator towards accepting the risk of SB occlusion versus proactively deciding to treat it, even if it costs more?
Yeah, this is where it moves beyond just the plumbing into the clinical relevance for that patient.
Yeah.
You have to consider individual patient factors. What's the absolute SB diameter and its length? You know, long, large SB feeds a bigger territory, so it's less acceptable to compromise it. You assess the takeoff angle, the amount of heart muscle, the myocardium that's supplied by that branch. Is that tissue even viable, or is it already scarred from a previous event? And then you look at the patient's overall status. Do they have ischemic symptoms? What are their comorbidities? How's their left ventricular function, their overall heart pump function? Basically, the bigger the territory at risk, the sicker the patient overall, and the more viable muscle there is, the higher the procedural need to preserve that SB, almost regardless of the resource cost.
Okay, so it's a very nuanced clinical decision, not just about the pictures.
Absolutely.
All right, moving into the procedure itself now. Let's tackle step 2, wiring and rewiring. This feels like where that tension between the ideal green approach and the necessary orange minimum really starts to show.
Absolutely. This is a key decision point, the recommended green approach. It's mandatory elective SB wiring, often using 2, sometimes even 3 wires, particularly for any clinically important SB and pretty much always for true bifurcation lesions. This establishes what we call the jailed wire technique.
Okay, the jailed wire. Let's unpack that a bit. Beyond just, leaving a marker in the SB for later, what critical mechanical advantages does that jailed wire actually provide that would justify the cost of using an extra wire?
Right. The jailed wire isn't just passive, it's an active mechanical tool.
Hmm.
Firstly, it physically helps to reduce the bifurcation angle, which can make getting back into the SB later after the MB stent is placed more straightforward.
Okay, straightens things out a bit.
Secondly, it's thought to actively improve SB patency while you're inflating the MB stent
Now,
by sort of holding the carina, that divider, in a more favorable position and maybe limiting how much plaque shifts over.
interesting.
Third, it provides a stable platform. If the SB acutely occludes, which can happen, you can often track a small balloon over that jailed wire between the stent struts and the vessel wall to quickly reopen it. It's a crucial safety net. And finally, sometimes it can act as an anchor for your guiding catheter, giving you vital support when you're trying to push bulky equipment into difficult anatomy.
Okay, so it does a lot more than just mark the spot. The source also notes that these polymer-coated or hydrophilic wires are safe to jail. If you are going to leave a wire jailed for potentially a while during the procedure, does the type of wire matter much in terms of, say, resilience or getting damaged?
It can, yeah.
Yeah.
Those hydrophilic polymer-coated wires are generally a bit more resilient to the crushing forces from the stent. They might be less likely to fracture or, lose their structural integrity when they're jailed. So, yeah, they're often the preferred choice if you're operating in that green zone.
Okay. Now let's pivot to the resource-sparing orange zone. What's the absolute minimum acceptable requirement for wiring here? And what's the high-risk scenario operators are basically accepting when they choose this path?
Right. The minimum is using only one wire, just the MB wire. Now, this is definitely a compromise,
Yeah.
and the manual is clear. It's only considered acceptable under very specific anatomical conditions. You need a favorable bifurcation angle, meaning more open, more obtuse.
A wider angle.
Exactly. And critically, there must be no severe disease in the side branch itself. The high-risk scenario you're accepting here, it's the potential for completely losing access to that side branch. If the carina shifts badly when you deploy the MB stent, or if the stent struts just block the SB opening, well, you don't have that jailed wire safety net anymore. The time and complexity needed for trying to rewire that SB blind goes up dramatically.
Yeah, that sounds stressful. Now, if the operator does choose this minimum one-wire approach, the manual includes a really critical technical tip for managing the inevitable need to potentially recross the distal MB stent struts later on. What's that tip?
Yeah, this speaks to the precision needed even when you're trying to save resources. To successfully recross those distal MB stent struts later, maybe to get into the SB if needed, the operator has to meticulously pre-shape the tip of that MB wire beforehand.
Pre-shape it.
Yes, pre-shape it. It needs primary and maybe secondary curves that are tailored specifically to match the SB angulation. Without that foresight, if you just try to jam a standard wire across later, you'll waste valuable time, potentially damage the stent structure with aggressive attempts, which ironically could end up requiring more materials in the long run to fix the mess.
So planning ahead even with the wire shape is key, and the obvious red zone warning regarding wiring. What should you definitely not do?
Well, using only one guide wire is explicitly not recommended. It's red in cases of true bifurcations where there's significant SB disease, or when you have a really unfavorable tight SB angulation. In those situations, the risk of losing the SB is just considered too high to justify saving one wire.
Got it. Okay, let's move on to step 3. Predilatation. To save money or time, just skipping predilatation altogether and going straight to stenting must be tempting. Why is optimal lesion preparation considered routine, the green standard, even before you put the expensive stent in?
Yeah, optimal lesion prep is directly linked to better long-term outcomes. It's really important. Predilatation with balloons, usually one or two, maybe semi-compliant SC or non-compliant NC types. It serves a couple of key functions. First, it modifies the plaque, kind of cracks it or compresses it, so the stent can fully expand and sit snugly against the vessel wall, what we call apposition.
Okay.
And second, it helps the operator gauge the true vessel size accurately before deploying that costly MB stent. Because if the stent is poorly expanded or not fully opposed because the plaque was too tough, the risk of problems down the line like stent thrombosis or restenosis, where it narrows again, just skyrockets.
Right, so preparation prevents future problems. What then allows for the orange minimum approach, which is direct stent implantation using 0 balloons for predilatation? When is that okay?
Okay, this is a highly restricted approach. It's really reserved for specific subsets of patients. Primarily, you might consider it in acute coronary syndrome ACS cases.
Vortex.
Yeah, where the lesions are generally softer, maybe contain fresh clot rather than dense, hard calcified plaque.
No.
The absolute prerequisite, though, is that there must be zero angiographic signs of fibrotic or calcified tissue in the MB or the SB. You have to be pretty confident it's a soft lesion. It's a calculated risk, essentially trading off potential suboptimal expansion for immediate time and material savings, but only when the anatomy really suggests low resistance to stent deployment.
Makes sense. Now, the use of SB predilatation seems quite controversial. Why does the manual explicitly state that routine SB predilatation is not mandated? What's the risk there?
Yeah, routine SB predilatation introduces significant risks created by the procedure itself, iatrogenic risks. The main danger is creating a dissection, a tear in the lining of the SD ostium, especially if you use an oversized balloon or the anatomy there is already complex.
Oh,
And that dissection, it can then make it easier for your wire to accidentally go outside the stent struts when you try to rewire the SB later. That can lead to a distal dissection further down the vessel or just a poor result at the ostium. So SB predilatation is really reserved only for specific, difficult situations. Maybe very difficult wire access into the SB, severely calcified lesions that you know won't yield, or if there's already compromised flow in the SB that needs immediate restoration.
okay, so use it very selectively. And if an operator does perform SB predilatation, there's a clear red warning about reusing balloons, isn't there?
Absolutely. This is critical. The operator must not use the same balloon that was used for MB predilatation to then dilate the SB unless the distal MB and the SB happen to have very similar diameters.
Why not?
Because if you take a balloon size for, say, a large proximal MB and inflate it in a much smaller SD, you risk rupturing that smaller vessel, causing a potentially catastrophic dissection, or just aggressively shifting the carina because the balloon is way too big. Sizing integrity here is absolutely non-negotiable.
Right. Got it. Don't mix and match improperly sized balloons. Okay, we've laid the foundation, we've prepped the lesion. Let's move to step 4, MB stenting. This is really the core of that provisional strategy. What defines the green gold standard here?
Right, the standard is deploying drug-eluting stents, or DES. These are generally preferred for better long-term results, and stent diameter sizing is absolutely critical. It must be based strictly on the reference diameter of the distal MB segment.
The distal, not the proximal. The proximal part of the main branch is often much larger, isn't it? Why wouldn't you size the stent for the bigger proximal diameter?
That's a great question, and it's counterintuitive but crucial for safety. If you size the stent to match the larger proximal vessel diameter, you will inevitably significantly oversize the stent in the narrower distal segment, down near the bifurcation.
Okay.
Oversizing there increases the scaffolding diameter right at the carina. This aggressively displaces the plaque mass, leading to significant carina shift, which, in turn, severely increases the risk of acutely shutting down the side branch.
Ah, so sizing big proximally hurts the side branch? Miscalo?
Conversely, if you size the stent based on the distal segment diameter, you ensure optimal apposition where the vessel is narrowest. You then rely on post-dilation, specifically the POT technique, to properly expand and oppose the more flared proximal segment of the stent.
Okay, size to the distal, optimize the proximal later. Makes sense. The manual also really highlights the importance of stent length. It says the MB stent needs to extend at least 8 to 10 millimeters proximal to the carina, that dividing point. What's the procedural consequence if an operator tries to save a bit of money by choosing a shorter stent?
Well, the major consequence is that you lose the ability to safely perform the proximal optimization technique, or POT, which, as we'll discuss, is essential for correcting malapposition. If the stent doesn't extend far enough proximally, when you go to do POT with your balloon, the inflation zone might end right on or even beyond the proximal stent edge. Yeah, that can cause trauma, edge dissection, or even deform the stent outside the area you intended to optimize. That compromise is just not worth the few millimeters of stent length you might save.
Okay, don't skimp on the proximal length. Now, what if DES, the drug-eluting stents, simply aren't available due to severe resource constraints? What's the orange minimum regarding the type of stent? Can you use the older bare metal stents, BMS?
Look, BMS are really only considered acceptable under pretty extreme circumstances, and critically, only when paired with a provisional single stent strategy that includes absolutely meticulous post-stenting optimization. However, the expert consensus really limits this practice almost exclusively to situations where the side branch is very small, typically less than 2 millimeters in diameter. The resource constraint here has to be weighed very carefully against the known much higher restenosis rates you get with BMS, especially in larger vessels. you're essentially accepting a significantly higher long-term clinical risk for that patient.
So it's a last resort, really, for very small side branches. Let's nail down the specific red flags for the stenting step itself. What are the big no-nos?
Okay, the definite red practices include using two-stent techniques like culotte or crush with bare metal stents. The long-term failure rate there is just unacceptably high.
Uh-huh.
Also, generally avoid using older closed-cell stent platforms for complex bifurcations, especially with large side branches. They tend to be stiffer and less conformable to that tricky osteal geometry compared to newer open-cell designs. And, as we just discussed, significantly oversizing the MB stent relative to the distal MB diameter is strictly discouraged because of that high risk of carina shift and SP compromise.
Right. Okay, that brings us perfectly to step 5A, the proximal optimization technique, or POT. You mentioned it's crucial. Why isn't POT just an optional nice to have? Why is it considered a routine requirement in provisional stenting?
Yeah, POT is absolutely fundamental. It addresses three key structural problems that arise when you place a cylindrical stent into a vessel that's naturally conical or tapered. First, it corrects the inevitable stent malapposition where the stent isn't touching the vessel wall in the proximal MB, which is usually wider than the distal MB where you size the stent.
Okay, fixes the gap.
Second, it helps restore the circular shape or geometry of the proximal vessel, which might have become elliptical after the stent was initially expanded. And thirdly, and this is really critical for the provisional strategy, it actively modifies the orientation of the SB ostium. It helps push the MB stent struts open at the side branch opening, making it significantly easier and safer to rewire the SB later, if needed. It helps prevent the wire from tracking outside the stent.
Okay, so it helps with apposition, shape, and SB access. Lots of benefits. If we're following the green standard, the ideal approach, how exactly is POT performed to get the maximum benefit?
Right? For the green standard, you use a short, non-compliant NC balloon. NC is important because it delivers high, predictable pressure without growing too much in diameter unexpectedly.
Precise pressure.
Exactly. It should be sized about zero point 0.5 to maybe 1.0 millimeters larger than the proximal MB reference diameter, or the stent diameter, depending on how you sized. And the positioning is key. The operator must place the distal marker of this short balloon precisely in front of the carina. This ensures the entire high-pressure inflation happens only within the proximal stented segment. This technique gives you maximum proximal apposition without messing with the distal stent segment or potentially compromising the SB ostium.
Short NC balloon, proximal to the carina. Got it. Now back to the material scarcity problem. If those specialized non-compliant balloons aren't available, what's the orange minimum requirement? Can you use more standard semi-compliant SC balloon? And what does the operator need to anticipate or plan for if they do?
Yes, an SE balloon may be considered, but you have to understand it introduces a new level of risk. SE balloons tend to grow larger, sometimes unpredictably, under high pressure. This could lead to over-dilating the segment or just making the inflation less controlled.
Right, less predictable.
So the key resource-saving maneuver here requires, frankly, extraordinary foresight during planning. The initial MB stent selection, particularly its length, must anticipate the need to use the shortest available SC balloon for POT. By planning from the start to use the shortest SC balloon you have for POT, the operator maximizes resource efficiency and minimizes the chance of that balloon extending too far distally and causing problems.
Wow, okay. That planning complexity really highlights the difference between just being technically proficient and being a truly resource-tailored expert operator. What's the major red flag regarding POT, the thing you absolutely must not do?
The unforgivable mistake, the big red flag, is to post-dilate the MB stent distally to the carina, using a balloon that's sized for the proximal MB diameter. This constitutes aggressive overinflation in a smaller vessel segment right at the bifurcation point. It will almost certainly catastrophically aggravate carina shift, potentially leading to acute, maybe even irreversible, SB occlusion. The optimization must stop strictly proximal to the bifurcation itself.
Okay, crystal clear. Keep the big POT balloon out of the distal segment.
All right, so once the MB stent is in and optimized with POT, we then reassess the side branch flow and anatomy again. The conventional final optimization step, if it's needed for the SB, is kissing balloon inflation, or KBI.
Okay, KBI. Now, is this a routine requirement like POT was?
No, absolutely not. And this is a really important distinction, backed up by randomized trial data. KBI is not routinely recommended in provisional bifurcation PCI. It's only indicated if there's severe persistent stenosis remaining in the SB, typically defined as greater than 75% narrowing, or if there's significant flow impairment, like TMI flow grade less than 3.
So it's a bailout or correction tool, not routine finishing.
Exactly. KBI is reserved for correcting a suboptimal result or failure, not for routine optimization just to make the picture look perfect. When it is necessary, though, it serves a dual function. It restores flow, and it also corrects strut malapposition right at the SB ostium and helps centralize the carina.
Okay. So when KBI is deemed necessary under the ideal green standard, what materials does it typically require?
Right. Proper KBI requires two non-compliant balloons. One size precisely according to the distal MB diameter, the other size precisely to the SB diameter. They're inflated simultaneously, making sure there's just a short proximal overlap of the balloons inside the main MB stent. The need for two separate, specifically sized NC balloons inflated at the same time means KBI is materially expensive. Two balloons, two inflation devices.
Yeah, that sounds like a major resource bottleneck, needing two of everything simultaneously. How does the orange zone offer some savings here? What are the alternatives?
Okay, there are basically two main resource-sparing approaches described. First, a simple reuse strategy. Remember that balloon used for MB predilatation way back in step 3? If it was correctly sized to the distal MB diameter and if you saved it?
Ah, plan ahead again.
Exactly. If you planned ahead and saved it, it can potentially be reused as one of the two balloons needed for KBI. This requires that initial planning to treat the predilatation balloon as potentially a multi-use resource throughout the case.
Okay, reuse the predilatation balloon if possible. What's the second, maybe more sophisticated alternative? You mentioned something called the POT side POT technique. You said this drastically reduces material needs. How does its procedural mechanism achieve that saving compared to KBI?
Right, POT side POT. It's structurally quite different from KBI because it never requires two balloons to be inflated simultaneously. You're essentially using the same short POT balloon multiple times in sequence. This saves resources primarily because you only need that one specialized short NC or maybe SC balloon that you use for the first POT, and you only need one inflation device operating at any given time.
Okay, only one balloon needed, used sequentially. That sounds much more efficient. Let's walk through the 4 steps of POT side POT just to make sure we understand its material efficiency clearly.
Sure. It goes like this. Step 1. Immediately after you've stented the MB, you perform the first POT using your chosen short balloon. Remember, the jailed wire is still sitting in the SB at this point. The goal here is to prep the proximal stent and start opening up that SB ostium access.
Okay, first POT done.
Step 2, wire exchange. This is important. You carefully maneuver the MB working wire into the SB. Then you completely retract the wire that was jailed in the SB and then re-advance that wire into the distal MB. This ensures you have optimal wire position in both branches for the next steps.
Right, swap the wires.
Step 3, SD dilatation. Now you advance an appropriately sized NC or SC balloon into the SB over its wire and perform the SB dilatation to address the osteostenosis.
Okay, open the side branch.
And finally, step 4, second final POT. You remove the SB balloon, and then you immediately perform the second or final POT using the exact same short balloon that you used back in step 1. This gives that final optimization to the proximal MB and carina region after the SB has been addressed.
Wow. Okay, so that single short POT balloon gets used twice, optimizing the MB both before and after the SB intervention. That means the operator effectively gets the structural optimization benefits similar to KBI, but using significantly fewer materials. That really is an elegant resource strategy.
It really is the epitome of procedural efficiency when resources are tight. It recognizes that the most critical functions of optimization, good stent apposition and reshaping the ostium, can often be achieved sequentially, rather than demanding simultaneous inflation with multiple devices.
Makes perfect sense. Now, what's the hard red warnings surrounding this final optimization step? What if you're tempted to skip it altogether?
Yeah, the manual is very clear on this. You should never skip the final optimization step, whether it's KBI or the final POT and POT side P2T, especially in a single stent bifurcation PCI if you started with a true bifurcation stenosis. The long-term risk of failure, things like restenosis or even stent thrombosis, is considered simply too high if you omit that final optimization step in these complex anatomical situations. Don't skip it.
Okay. Final optimization is mandatory for true bifurcations. All right, up to this point, we've really focused heavily on the provisional strategy, using just one stent in the MB if possible. But step 6 in the manual covers the decision to actually deploy a second stent into the SB. This is a decision that immediately escalates the complexity, the cost, and the risk, right? What triggers making that move?
It is a monumental decision, absolutely. Because remember, a poorly executed second stent technique could actively jeopardize the result you've already achieved in the main branch. Therefore, the trigger to commit to two stents shouldn't just be based on how it looks on the angiogram. It really must be based on clinical and functional parameters,
Like what?
like clear evidence of ongoing ischemia related to that side branch, or maybe formal functional testing showing that the stenosis is hemodynamically significant. It has to be more than just, oh, the ostium looks a bit pinched.
So a functional reason, not just a cosmetic one. When are systematic two-stent strategies truly warranted then, even if you are in a resource-constrained environment where every stent counts?
Generally, they're reserved only for the most complex situations. We're talking about true bifurcation lesions involving large side branches that have significant diffuse disease, meaning the narrowing extends quite far down the SB, maybe more than 5 or even 10 millimeters. Or perhaps in cases where, despite your best efforts during the provisional approach, getting a wire back into the SB is proving extremely difficult or seems impossible. Sometimes converting to a two-stent strategy is the only way to secure that branch.
Okay, so large diseased SBs, or very difficult access. Now, the choice of which two-stent technique to use is heavily dependent on the bifurcation angle. Let's look at the wide angles first, typically wider than 70 degrees. What are the options there, like T-stenting and TAP-E, and what are their material and procedural implications?
Right, for those wider, more T-like angles, the recommendations are typically T-stenting or TAP. T-stenting aims to place the SB stent right up against the MB stent, ideally with minimal or no protrusion into the main branch. TAP-E stands for T and small protrusion. Here, the operator intentionally deploys the SB stent with a tiny controlled protrusion into the MB.
Why protrude intentionally?
The idea is to absolutely guarantee full coverage of the SB ostium. While this might make the final KBI technically easier to perform because the ostium is definitely scaffolded, the downside is that you create what's called a metallic neocarina, basically a small metal shelf hanging inside the MB. This must be fully addressed and optimized with KBI, which adds to the procedural complexity and time. TTAP might be slightly more resource-intensive because of that meticulous placement and mandatory final KBI.
Okay, T or TAP for wide angles. What about the narrow angles, less than 70 degrees? These often involve the most complex techniques like culotte and DK crush. Can you contrast their approaches and maybe their material demands?
Yeah, narrow angles usually demand different strategies. Culotte or DK crush are the main ones mentioned. The culotte technique is often better suited when the SB and the distal MB have similar diameters. It involves essentially stenting both branches and creating a trouser leg appearance where the stents overlap proximally. It can sometimes be seen as a staged extension of a provisional strategy if you decide late to stent the SB. It definitely requires 2 full-length stents and multiple sequential balloon inflations, including a final KBI.
Okay, culotte for similar diameters. What about DK crush? That sounds intense.
DK crush, or double kissing crush, is arguably the most complex and often the most resource-intensive technique, but it's frequently necessary for very challenging narrow-angled true bifurcations. It's a highly structured, multi-stage procedure. Briefly, you stent the SB first, then you crush the protruding part of that SB stent against the MB wall using a balloon from the MB. Then you have to rewire the crushed SB stent, preferably aiming for a central recrossing through the crushed struts, and perform the first KBI. Then you stent the MB, and finally you finish with a mandatory second KBI.
Wow, 2 KBIs.
Yes, the requirement for 2 separate mandatory KBI procedures means this technique rapidly escalates the material cost. It demands a significant investment in balloons, time, and operator expertise.
Okay, very complex, very resource heavy.
Uh,
In these complex two-stent procedures like culotte and DK crush, are there any material saving minimums, any orange zone tips that an operator can still employ?
yes, the key saving often comes back to the balloons. In both culotte and DK crush, the manual suggests that operators should plan to reuse the stent delivery balloons, the balloons that were actually used to deploy the stents themselves for performing the final KBI, assuming they're appropriately sized.
Ah, reuse the delivery balloons.
Exactly. This can save the cost and time associated with opening additional specialized NC balloons just for that final kissing inflation. However, the rule remains absolute here. The final KBI step in any two-stent bifurcation procedure should not be skipped. Skipping the final optimization in a two-stent case is definitely a red, potentially dangerous practice, regardless of resource constraints. It critically increases the risk of thrombosis or restenosis, especially where the stents overlap or are deformed.
Right. Final KBI is non-negotiable for two-stent strategies. Okay, finally, let's briefly touch on intracoronary imaging guidance, things like IVUS, intravascular ultrasound, and OCT, optical coherence tomography. These tools offer incredible precision, the ultimate view inside the vessel, but they obviously come with a high financial cost. Should they be considered routine in bifurcation PCI?
Yeah, that's a million-dollar question, literally sometimes. The manual acknowledges that while intracoronary imaging certainly hints at potentially favorable effects, helping with stent sizing, assessing expansion, checking apposition, its routine use globally is still limited. Why? Primarily due to the high cost, and also because we currently lack definitive large-scale randomized evidence that mandates its use in all provisional bifurcation cases to improve outcomes. Therefore, the green recommendation for using imaging is more targeted.
Okay, so how does the manual recommend they should be used, especially in a resource-tailored environment? When is the cost justified?
They're generally reserved for selected complex interventions. Specifically, the manual highlights their value in double stenting procedures, both for pre-procedural planning, really understanding the vessel sizes and plaque, and for post-implantation evaluation, checking the final result. OCT in particular offers a unique safety advantage. It's incredibly valuable for determining the exact position of your guide wire after you've rewired the side branch, especially through stent struts.
Why is that so critical?
It's critical for preventing something called abluminal rewiring. That's when the wire accidentally tracks outside the stent, struts, and tunnels into the vessel wall itself. This is a high-risk event that can lead to major complications like perforation or late stent failure. So if an operator suspects they might have accidentally rewired abluminally, maybe the wire path looks funny, or balloons aren't passing easily, using OCT to definitively confirm or deny the wire position is seen as a very justifiable use of a costly resource. It can potentially avert a catastrophic vessel complication.
Okay, so use imaging selectively, especially for complex cases like two-step procedures, and definitely use OCT if you suspect abluminal rewiring.
Precisely. Hashtag outro. What this manual ultimately proves, I think, is that facing resource constraints doesn't automatically mean you have to compromise patient care. This resource-tailored approach, it's really all about prioritizing procedural safety and good long-term outcomes through meticulous planning, having a clear structure, and frankly, foresight. By clearly defining those orange minimums, whether it's the one-wire technique when appropriate, targeted predilatation, or using elegant alternatives like POT-side POT optimal patient treatment absolutely remains possible, even when your inventory levels are dictating the limits of your operational choices day to day.
Yeah, this has provided just an extraordinary depth of detail on operational strategy and cardiology. It's fascinating. And I think for you, the listener, the essential lesson here is that efficiency in this demanding field is really an intellectual effort long before it becomes a manual one. Knowing why you can sometimes safely use just one wire, or understanding the specific conditions under which direct stenting might be acceptable, that's what defines the successful, resource-sparing operator. Now, we focus today mostly on maintaining procedural safety while saving materials in the short term. But considering the significant long-term risks associated with stents, particularly things like stent thrombosis, here's a final thought for you to perhaps mull over. What critical procedural step, if it were skipped due to resource constraints, maybe a final KBI or even POT, do you think carries the highest future clinical cost for the patient down the road? That's where the true difficult calculus of practicing medicine under pressure really lies, isn't it?
That's a tough question, but a crucial one. Thank you for watching The Funnel Effect.